Facilities that make this program possible are provided by the City of Highland Park. Programs are produced independently by members of the community. The City of Highland Park is not affiliated with the following program or the producers of public access programming and is not responsible for the content. The following program does not reflect the opinions of the City of Highland Park.
Welcome to Chill Out. My name is Pam Chill, and I'm hosting Chill Out. And today's program is What is Depression and How We Can Treat It. I have my very special guest today. I'm so privileged to have her on. She's Dr. Geeta Bansal, MD, a neurologist and psychiatrist. Welcome to the program. Thank you. I'm just going to give a brief bio. You're what's known as a triple threat. Okay, not only are you talented and beautiful, you are a neurologist, psychiatrist, and board-certified neuromuscular specialist. So how did that all come about? Why did you go into all of that?
So I think I originally went into neurology because my dad's a neurologist, and so it was very comfortable. I grew up with it. I always loved learning about behavior too, and because behavior comes out of the brain, I couldn't separate the two of them. So that's why I decided to do both neurology and then psychiatry.
Excellent. So you're Ivy League trained? Ivy League?
Yeah, I did my residency at University of Pennsylvania.
Okay, excellent. All righty. So in your practice, what type of cases do you see in your practice?
So I think the way I want to start off is just give you two cases that are actually quite common that I see that present as depression cases, but the patient or the referring physician sometimes doesn't even realize that it's a depression case. So the first one I'm going to talk about is a 21-year-old female, okay? So she's a 21-year-old, very high-achieving female. So growing up, she grew up in the Vernon Hills area. She was valedictorian of her class. Always had lots of friends, was doing great, until her senior year of college, when she noticed that her grades went from a 4.0 average to about a 2.8, 3.0 average, okay? And so she came to me because she said that I'm having trouble thinking. Like when I'm trying to read something or process something, it's just not like going into my head, okay? So her primary care doctor had thought that she was depressed, so that was another reason that he had referred her to me. So upon further questioning, she told me that she wasn't sleeping as well. So she was falling asleep at midnight and waking up at 4 in the morning. She had lost about 20 pounds because she wasn't hungry. She was apathetic. She didn't feel like doing things like she normally used to do. She used to love to hang out with her friends, play the piano. All of the things that she would find very interesting to do, they were all wiped out, okay? Her mood, she did say she was sad, but that wasn't the primary feeling that she had when she first presented. And then back to her schoolwork. So then when she told me she was trying to like study for her classes and read, etc., she said that when I would read, it would go in one ear and out the other. Or when I would hear the teacher speak, it would go in one ear and out the other. And she just could not get it together. Okay? So we did, obviously her primary care doctor did a great job doing her medical workup, and we always look for thyroid and B12 deficiencies, etc., because those can look like depression. Those were all normal. Okay, so I want you to keep those in mind, and then I'm going to present my next case. So the next case is a different demographic, but just as important. He's a 55-year-old gentleman. He had medical problems of diabetes and high blood pressure, but really well controlled. Okay, so his wife actually was the one who brought him into treatment because she said, you know what, my husband is having a lot of memory problems. I think he has dementia. Okay, so, and the husband had noticed, so he was an insurance salesman, okay, and he had noticed that he was making mistakes that he would have never made before, okay, like simple things, calculations, account stuff, everything. He was just making a big mess out of, and normally he was a very like careful, cautious, smart guy, okay. Upon further questioning with him, he was sleeping all day long. He had gained about 30 pounds. He was very apathetic. He didn't really describe his mood as sad, but more apathetic. He was also having feelings of guilt that just kind of came out of nowhere from his childhood. I remember he was a little bit of a bully growing up, which he regrets, but things going on from about 40 years ago were kind of bothering him more than they should have, okay? And then he had some suicidal thoughts as well, okay? So in both of these cases, what we see is that these are patients who are having changes in sleep, changes in motivation, changes in appetite, changes in behavior, changes in attention processing learning materials, right? Sadness, not being able to enjoy things that they used to enjoy. And what part of the body is the problem here? It's the brain, right? So depression is a brain disease. I want to show this first slide here.
Okay.
So the brain on the left side, that's a normal, very active brain, okay? Very normal when somebody who's not having a major depressive episode. On the right side, so look at the bright colors. Let's focus on the bright colors. So bright colors is good according to the scan, okay? So on the right-sided picture, the patient with depression, look how inactive it is, okay?
Oh, yeah,
Because
it
it's a brain disease, so the whole brain is not working properly. It doesn't light up the way it should. I know a lot of times depression gets delegitimate or is not as legitimate compared to other diseases like heart disease, et cetera. But it is a real disease, and so that's why I put this slide up.
Now, what kind of scan was taken?
This is a PET scan, and a PET scan shows activity in the brain.
Oh,
Okay, so again, left side, very active. So that's why the person can think well, they can eat well, they can be motivated, they can do all the things that they normally want to do, but then on the right side, it's just like, ugh.
So this is really an affirmation of a diagnosis as well.
Absolutely, absolutely, yes.
Okay, so what is the prevalence and incidence that you see in depression?
Okay, so the prevalence, this next slide kind of summarizes this. So worldwide, there's about 121 million people with depression, okay? The slide is a little unclear, but basically the prevalence in the United States for depression is about 20 million, okay? 20 million. Amongst those, 4 to 5 million contemplate or actually go about committing suicide. It's a very serious disease, okay? Some risk factors for depression are being female, okay? So there's about a 3% risk, absolute risk difference between males and females with
Do
depression.
you think it's hormonal?
I do think it's hormonal because a lot of the times when females get depressed, it is during, when they reach puberty, and then also the next stage of life, which is menopause. So we see peaks in those times.
Is this something, just going back to that briefly, with the cycle, are there periods in the cycle time
Absolutely.
that you see more depression?
Absolutely. And what's interesting, both in neurological and psychiatric disorders, it's not the hormones per se causing the problem, it's the shift. So right before ovulation, it's that shift of progesterone, it's that shift of estrogen that causes the problems. And that's why during pregnancy itself, sometimes it can actually be protective for depression because why? You have a high level of progesterone, estrogen throughout the whole cycle. But then postpartum, what happens? All those hormones they all go down, right? So that's why we have a lot of postpartum depression, postpartum blues, etc. So it's shifts of the hormones.
Okay.
Some other risk factors of depression, as the next slide kind of shows, is that low socioeconomic class, African Americans have a higher incidence of depression, and so do Native Americans.
Oh, I wonder why.
I don't know yet. We don't know yet.
It's because they don't have the opportunities? They
That's
just
true,
feel
because-
kind of maybe a defeatist attitude?
Defeatist attitude right from the beginning. I mean, there's a lot of prejudice. They just don't feel like they have the opportunities that other people have.
Well, we have our next slide on, so if you want to...
So this slide basically just demonstrates that depression is a multifaceted disease, okay? We have a biological predisposition. We don't know the exact genes implicated, but there's a concern that some people with a particular serotonin receptor gene have a higher propensity towards depression. And then psychological factors, right? So if we grew up in a very negative environment, if our parents were very critical, more than the average, if we've been through a lot of traumas growing up, like rape, any type of physical abuse, emotional abuse constantly, I mean, of course we're going to develop, that's going to be a risk factor for depression. But again, you can't forget the biological predisposition. Not everybody who gets, who's under trauma develops depression, right? So just like not everybody who goes to war develops PTSD. Only a certain number of people do, so that's why we also know it's a very biological disease. And it's really important, the social aspect of it. People who are very isolated, like people who have just gotten a divorce, or people who have just lost their job and their social kind of outlet, that's also another risk factor for depression.
Mm-hmm. On the psychological social factor slide, did we do that one yet? That one?
I believe so.
Okay. And how do you diagnose? I think that one is that one right there. Yes. So if you want to explain a little bit about that slide, what we
So
have
the
there?
way we diagnose depression is the reason I had kind of pointed out some of the key features of the first two patients was it's a clinical diagnosis.
The 21-year-old female
and the
55-year-old
male.
male. Two totally different demographics. But
Exactly.
what do they have in common?
Look
Right.
at what they have in common, right? They both had changes in sleep, right? So one person had what we call early morning awakening. The 21-year-old female had early morning awakening. What does that mean? That means that she goes to bed at whatever time she wants to go to bed, 11 or 12 or 10, and then she wakes up at 4 in the morning. For some reason, some patients with melancholic depression don't need that extra REM in the morning. We don't know exactly what the cause is, okay? So they have changes in sleep. Some people sleep too much though, okay? All they do all day, like the 55-year-old guy, he was sleeping all day long, poor guy, okay? So no energy. Then you can have changes in appetite. The second patient was eating all the time. The first patient, she lost 20 pounds, okay? Feelings of guilt is very common in depression. Just like the 55-year-old gentleman, he was having feelings of guilt from, I mean, yeah, he didn't do the right thing bullying as a kid, but I mean, that's over and done with. He's apologized to everybody, but now it's kind of creeping up. And in that negative, depressive, ruminative brain, that's what happens. You start having feelings of guilt that you don't need to. Energy level changes. Usually the person just has no energy. They feel zapped all the time. Trouble concentrating. So this is an important point. You know the second patient we talked about, the 55-year-old gentleman?
Yes.
So he and his wife thought he had a memory problem, okay? He did not have a memory problem. I did extensive memory testing on him. He had a processing or concentration problem. So think about this, okay? So when we have to remember something, we first have to hear it or see it, right?
Well, they say 3 times and then you will.
Yes.
Recollection.
Exactly. And then we have to process it. Only when we process it can we encode it into our brain, and only once it's encoded can we retrieve it. Memory is the retrieval process, but these patients have trouble with concentrating and processing. So that's why the young lady said it goes in one ear and out the other. It just does not stick because
And it
that brain is
used
just
to.
not
She
working.
probably
It used to.
had-
She was a valedictorian of her high
She
school.
probably had a
She'd have-
photographic memory.
Exactly.
She would probably see it one time and then had total recall of
And
it.
that was so scary for her. That was the scariest part for her. It wasn't her sad mood. It was, look, I can't even study anymore. That's scary.
Now, is that some type of an attention deficit disorder? or
It's
is
not.
just
So many
depression?
times, people can, it's an attention problem. Absolutely, you're right. It's an attention problem. And some people may misdiagnose it as ADHD or attention deficit disorder. But if you don't get a good, thorough history, you're going to miss depression. So ADD can be a mask for depression because your attention sucks when you're depressed, right?
Right.
So don't sit there and give them Adderall. I mean, you have to get a full longitudinal history. Maybe they did have ADHD as a child, et cetera, but these cases are very different. Their primary problem is a mood problem, is a neurovegetative problem. So that makes a big difference. And then the rest of them, psychomotor retardation is one of the criteria, which just means you just are kind of blah all the time. And then some people do have suicidal thoughts, unfortunately, like my 55-year-old gentleman.
Now, talking about those cases, you were also talking about clinical criteria that's used, like you use in heart disease.
Correct.
But you're actually transferring that to neurological and psychiatric.
Yes.
Right.
So that's our goal these days, okay? So the next slide shows that although depression right now is diagnosed as a clinical diagnosis, and by clinical I mean we go over the criteria that we went over before, those SIGI caps. That's kind of the mnemonic that we remember to learn the criteria for depression. But we're not so naive that we don't know the part of the brain that's affected, at least in part. So this is called the dorsolateral prefrontal cortex. Basically, all it means is that the frontal lobe, there's an anterior part of the frontal lobe, which is actually the most evolved part of the brain that no other life forms have. Only humans have it, okay?
Really?
And yes.
So interesting.
Yes. And the next slide kind of shows us what does this part of the brain does. Basically, just to make it simple, it gives us attention, it gives us emotional reactions, it gives us insight, it gives us behavior, it allows us to plan things out. That's why if this part of the brain is not working well, just like you mentioned, the person can look like they have ADD, right? And then the next slide kind of shows us that the blue is the blue color is where you'll see the dorsolateral prefrontal cortex again, and it's what we call quote unquote hypoactive, just like I had shown the first slide. So it's not working as well as it should. And if that major part of the brain is not active as it should, then it can't control other parts of the brain, right? And so those other parts of the brain take over, and the patient's brain is just not functioning like it should, and that results in depression.
Now, what type of treatments do we have now? I hear there are a lot of new techniques, especially that you're working with, to treat depression.
Sure. This is kind of a fun time to be treating depression. I always tell my patients, even though they come in with lack of hope, because it's just a very horrible disease to have. Like, it's very uncomfortable, it's miserable, and it's not, people don't like really understand that it's a true disease. So the first place we start is because there's a biological predisposition, because there's a true biochemical problem in the brain, I do start with medications if the patient has moderate to severe depression, okay? So basically this next slide shows us the 3 neurotransmitters or the neurochemicals that are dysfunctional in the brain, okay? We just don't have enough of those 3 chemicals, and they are serotonin, norepinephrine, and dopamine. So you've probably heard of the medications like the Prozac, Lexapro, Zoloft. Okay, so there's a ton of them now, and we see them on TV and stuff. So I'm going to kind of just break them down, just kind of simple breakdown. The most common ones we hear about are Prozac, right? Prozac, Lexapro, Zoloft, Celexa.
And the generic, too.
And the generics, which are citalopram, fluoxetine, sertraline. Those just work on serotonin. So those increase the level of serotonin, okay? That's usually standard of care. That's the first drug we go to. Why? I'm not saying that that's the most effective, but that's the most tolerated, okay? That has the least amount of side effects. It's probably been studied the most, okay? The next class of drugs that I usually go to, and everybody's different, so at this point, I don't just start with serotonin reuptake inhibitors and then go to this and then that. I usually can kind of pick out which patient will do well on which drug. But the other classes of drugs are serotonin norepinephrine reuptake inhibitors. Basically, they increase serotonin and norepinephrine. Those are medications like venlafaxine, Effexor, Cymbalta, and then you have dopamine. We can't forget about dopamine. So you have medications like Wellbutrin or bupropion that can kind of increase the deficit of dopamine, those medications. And that's just to name a few. I mean, these days there's a lot more medications, but.
Okay, and what if someone doesn't want to take medication?
Okay, so that is completely fine. With this day and age, we have plenty of other treatments. So like I said, medication is not the only treatment. Even when I give medications, we have to work on the psychological aspect of it, the social aspect of it, and the biological, remember, okay? So with medications, whether they want to take medications or not, therapy is really important. So there's another slide about therapy, cognitive behavioral therapy. So the cognitive behavioral therapy is
I'm looking for the slide here.
Cognitive behavioral therapy is basically the most validated therapies. Like there's most evidence behind it. Okay, like it really works in depression, anxiety. There's some trials that it even works in mental illness like schizophrenia. And what it does is it tries to attack or get rid of the vicious cycle of how negative or distorted thoughts contribute to poor behavior choices and then poor emotions. So let me give you an example. The first thing we notice is emotion, right? So pretend I'm feeling sad today, okay? Or automatically I'm feeling a sad thought, okay? Or a sad feeling, okay? A sad feeling. When somebody is depressed, the thing that happens next is they have an automatic thought that accompanies that feeling. So I'm feeling sad. The automatic thought is, I'm a useless human being. I'm good for nothing, okay? And then what am I going to do? I'm going to go in bed and lay down. Then what's going to happen? My emotion again is going to be even worse. I'm going to get more sad. And then I'm going to think again, I really suck now. And so there's this vicious cycle and triad of emotions affecting thoughts, which affect behavior. I'm going to give one more example of CBT because I really respect CBT and I really think it works.
Oh,
so
down on the side.
Yes. So where it says emotion, so the first thing we do is when we're just sitting here, right, whether we're depressed or not, we have an emotion. So an emotion could be anxiety. I'm nervous. I'm anxious, right? Automatically, a person with generalized anxiety disorder or somebody with anxiety is going to think, oh my gosh, something is wrong, okay? And what are you going to do when you feel like something is wrong? You're going to act out a behavior. That behavior is going to be calling your relatives. Are you okay? Are you alive? Are you doing this? Are you doing that? And then what's going to happen next? Pretend your mom is in the shower or something and she can't pick up the phone. The next emotion is going to be, I knew it. I'm anxious. I'm even more anxious now. I knew she just had a car accident and died. Okay? And then it feeds the next thought and then behavior. So CBT is, those therapists, what they do is they try to kill this vicious cycle and make it a less distorted thought pattern. There's another type of therapy that that I also think is very effective. I didn't put a slide about that one, but it's called psychodynamic therapy.
Oh, okay.
So where CBT works on a more conscious level, psychodynamic therapy works at the subconscious, okay? So it gets to the point where we have these internal conflicts that we're not even sometimes aware of, but it kind of changes and modifies our thought processes, okay? So psychodynamic therapy, it could be due to poor childhood traumas, it could be due to environmental stressors, et cetera, but psychodynamic therapy kind of gets to the core of those. So I just wanted to mention that therapy as well.
And holistic, is there anything that we can do like as far as holistic therapies?
Yes, so non-medication therapies, I'm really excited about, as a neurologist, I'm really excited about the new upcoming treatments of TMS. There's going to be a slide on what we call transcranial magnetic stimulation.
Yes, that was so exciting. You know,
Yes.
and I just want to interject that I read your brochure, A Ray of Hope, Leave Depression Behind, Achieving Well-Being Today. And I looked at that and I was like, oh my, this is really cutting edge
It is.
treatment of depression and giving people a viable alternative.
It is. It really is. Like even in the state of Illinois.
We have our slide on
Yes.
now.
Okay.
Yes.
So even in the state of Illinois, there's not that many deep TMS machines here. So let me talk a little bit about what transcranial magnetic stimulation is. You've been in an MRI machine, right?
I haven't.
You haven't,
I
but
know, but
it's a magnetic field. It's very safe. It's even safe in pregnancy, right? So a high magnetic field current, okay, is applied to the dorsolateral prefrontal cortex. That picture that I had shown in the beginning, the part of the brain that's not working, it's hypoactive, it's not working very well. This device goes directly to that part of the brain and wakes it up. It increases the activity to that part of the brain. There's two types of TMS. Superficial TMS was FDA approved, I believe, in the early 2000s. And deep TMS was, although it's been out since 2008, 2009 in Israel, it was FDA approved in 2013. I've seen more benefit with the deep TMS, and that's what I brought into my office. The beauty of deep TMS is that it actually penetrates 4 centimeters into the skull. Like it forms new connections. I'll show you the next slide. So deep TMS activates that part of the brain and then neurotransmitters are released. And that's how is simply how TMS works.
How soon do you see an improvement?
Oh gosh, it's amazing. So there's about 30 to 35 sessions that you see, and what's really interesting is you don't see an improvement right away, but what you do notice is, what my patients have told me is that around treatment 5 to 7, you start seeing an improvement in sleep, okay? The basic sleep, okay, which is a big deal for somebody who's been depressed and either sleeping too much or too less. It regulates their sleep.
How much should we get? The average for sleep?
So everybody's so different. Some people require 8 to 10 hours of sleep. Some people require only 6 to 8 hours. As we age, we actually need less sleep. So I would say 6 to 8 hours.
6 to 8 hours. Actually, if I slept 8 hours, my husband would think I was in a coma.
Right, me too. My husband too. I need about
about 4 to 5 hours is what I sleep.
Yes, that's how I am too, about 4 to 6 hours. But my husband needs like 10 hours, okay? Because if he doesn't get that, no, it's a disaster. Okay, but anyway.
And I think we were going to put your contact information for you. If you want more information regarding, different types of treatments, they can always contact you at, what do we have, Geeta?
Yeah, Geeta NM Neuro, GEETA NM Neuro@gmail.com.
Okay, thank you. Now, how do you recommend going about the treatment with all these different options? What is the first step for someone?
I ask the patient, I ask them, so what exactly are you looking for me today? First of all, I like to target particular symptoms, okay? So I always ask them, if I could help you with 3 things today, what would it be? And so that's how I start off tailoring my approach. And if I feel that they meet criteria for moderate to severe depression, and sometimes even mild, because that's also very disheartening for them, I ask them if they would like to try medication, or if they would like to try therapy. I do let them know that all the studies show that for moderate to severe depression, medication plus therapy is superior to either one alone. It's really important. If the patient has a lot of other medical problems, they can't tolerate medications, and they're in the moderate to severe category, I will try TMS on them if they would like to. Just to go back to the first 2 patients that we discussed, the 21-year-old female had actually been on 4 or 5 antidepressants prior to coming in to see me. At that point, I would say she wasn't even in a partial remission. So we tried TMS on her, deep TMS.
I just want to interject. Is that covered by insurance?
It is. It's FDA approved.
Okay.
In Medicare, which is the most annoying insurance, doesn't even ask any questions. So yeah, so she got TMS and she got better. But my second gentleman, we just tried regular medications and therapy because he had never tried that before.
Okay. And what other options? So after that?
The other thing I would do is taking control of this disease is really important, okay? So just like we take control in heart disease where we have to do some exercise rehab, we have to take our medications, we have to eat healthy, we can't neglect those in depression. We need to do moderate to severe exercise if the doctor allows us to do so. That's what the studies show us has been very beneficial. We have to eat brain healthy. That includes the omega acids, primarily like tuna, salmon, lots of greens. Really important.
Really?
We cannot neglect that. That's important for the brain.
Uh-huh.
And then having good social circle, having therapy, it's very multifaceted approach.
Okay. And we have our last slide that we wanted to show. We should have one more slide with a biopsychological
So basically,
model.
the reason I put up this slide is, again, just to highlight the fact that depression is a multifaceted disease. We got to target the biopsychosocial model. So biological, medications, okay, or TMS. Psychological, we have to see what is going on in that person's subconscious or conscious level as to why they have such distorted thoughts, okay, that make depression worse and more difficult to treat. So I do make sure that I have very good contacts with some therapists, and I make sure that we all work together for the patient. And then social, cultural influences. We got to make sure that we have a nice group of acquaintances or friends, or
do you think friends can actually turn someone?
I don't think if somebody has moderately severe depression, just friends alone can help. I just think it's nice to have them to share the dread that you feel. But I mean, people with heart disease, right? People with hypertension. I have a bunch of folks who tend to walk together. It's just a nice kind of collaborative effort, but I don't think it can. actually treat
Absolutely.
it.
Well, I'd like to thank you so much, Dr. Bansal, for enlightening us on the topic of depression and all the new innovative treatments that are actually out there. So no one has to feel that they are alone.
No.
That there are always other avenues,
No.
other alternatives.
Yes.
And if somebody does want to come and see you,